The following presentation is a pre-recorded webinar on end-of-life care for surgeons, presented by Dr. Buddy Marter from Wake Forest School of Medicine and Surgical Palliative Care Society. Thank you.
All right, well, let's get rolling then. So these are kind of the core competencies for what we consider to be primary palliative care skills for surgeons in this area. Recognize when your patient's life expectancy is short, compare and contrast different code statuses and apply those to perioperative care, explain the process of compassionate withdrawal of life support clearly and compassionately to your patients' families, and evaluate and manage pain, dyspnea, oropharyngeal secretions, and terminal delirium near the end of life. So, unfortunately, kind of like what Carl was saying, our culture embodies a bipolar attitude towards death. We avoid it, resist it, deny it, but simultaneously we sensationalize it. We portray it with outrageous violence, particularly in the media. And we kind of think about it almost as if it's an unnatural thing. And we're somehow overtaken by an external force unexpectedly that takes us by complete surprise. So this is just a contrast of kind of Eastern view of death versus a Western view of death. Americans also cling to medical technology as if somehow fantastically death itself was preventable or a glitch in our operating system. But we can't just blame our culture. Our surgical ethos demands essentially that we never give up. And as surgeons, we're fixers, right? That's what we do. We fix problems, and that's deeply ingrained in our philosophy. It's probably one of the things that attracts us to surgery to begin with, and then it gets more deeply ingrained as we train. But unfortunately, it fosters a self-defeating attitude towards disease progression, as if that's some kind of a failure, and we take it personally, or at least some of us do. So my question is, what if we began to see that death is not some alien outside threat that might strike at any time? Suppose that we embrace dying as a native property of every human, a central feature, a property of existence, a property of being. The Tao Te Ching says, being and non-being create each other. If we embrace that, how would it change our attitudes towards our own mortality and towards that of our dying patients? So this is an adaptation of what's called the bow tie model of palliative care. You can see the bow tie here. Disease-directed treatments is on the left, and as time progresses towards the right, those fail more and more often. I hate to use the word fail, but they become more narrow, if you will. And palliative care then ideally increases. Throughout the entire thing, we want to do good pain and symptom management. And palliative care doesn't necessarily end with end-of-life care. We're perfectly happy to help in palliative care, help patients survive and go to rehab and those kinds of things. So the question is, when in your patients' courses are you going to mention their prognosis? When are you going to mention death and dying? When are you going to begin to employ your primary surgical palliative care skills? When are you going to call an expert palliative care consult? On the brink of death, right here? Is palliative care the same as giving up? Lots of questions, and hopefully we'll kind of answer these questions as we go through today. The one thing that I think is not on this slide is hospice eligibility. And hospice eligibility uh, is based on an estimated prognosis of 6 months or less to live. So you just need to have two doctors say, in my best guess, this person is in the last 6 months of life. Unfortunately, in America, I think the average time remaining from hospice enrollment to death is something like 8 days. So we don't we all do a bad job of enrolling our patients in hospice and wait until the absolute last minute. This is an interesting study. Um, this is probably the best study that has been done looking at triggers for palliative care consults in the SICU. And it was done at Mount Sinai, 9-month analysis of 492 patients. They have a almost 1,200 bed tertiary medical center in New York. Their overall SICU mortality is 4.4%, and their average SICU length of stay is 5 days. But within those 492 patients, the 21 of them that had to come back, bounce back to the SICU, 81% of those either died in the hospital or were discharged to hospice. The folks with metastatic or advanced cancer, not many, right? Only 16, but 75% chance of dying. And then if they had at least what they called secondary criteria, which are all organ system failure, right? GCS less than 9, inotropes, GFR less than 30, that kind of stuff, 55% chance of dying. And if they stayed in the SICU for 10 days, 51% chance of dying. So those are kind of give you an idea of certain things that might tip us off that the time to employ our primary palliative care skills is near. This is ties a little bit back into your first talk today on vascular surgery patients. And this is a fascinating study because it's a 10-year analysis at Oregon University, 111 vascular surgery patients who died in the hospital. Interestingly, 81 of those 111 had a shift to comfort care, but 31 of those 81 patients were offered medical surgical treatments, but they chose comfort care anyway. That's pretty significant. That's three-quarters, like three-quarters of the folks that met these criteria. And here's the odds ratio compared to historical diagnosis matched controls. So if they were in the SICU over 5 days, 4 times chance that they shift to comfort care. Over 5 days of invasive mechanical ventilation, 10 times. New renal failure, dialysis, 14 times. Oh, baby, trach, 24 times. So again, these are things that might tip you off in your patients that, okay, it's time to start employing my primary palliative care skills and start having some very honest discussions about prognosis with this patient's family. The saddest thing on this entire slide is down here at the bottom. The median time from palliative care consultation to death was 10 hours. I mean, you can call me at the brink of death, and that's fine, and I'm happy to help. But I can tell you that at the brink of death, you have missed all kinds of opportunities. And the families at that point are essentially in a tailspin. So here's another study. This was done by Nabozny et al. In Wisconsin. And they looked at older adults who had high risk surgery, all Medicare beneficiaries, They looked at actually 10% of them because it was such a huge number across a 4-year period of time, almost 120,000 patients. And what they found was that a third of older adults who had high risk surgery and stayed intubated for 4 days post-op died within 30 days. Of the 30-day survivors, only 10% of them were discharged home. And the 1-year mortality, if you stay on a vent for 4 days post-op and you're older and you had high risk surgery, is 64%. So here's our own data. This is data that I pulled from our post-op ICUs, both the SICU and the TICU, and just looked at nephrology consultation, plus or minus whether CRRT was initiated. And it's an 11-month period of time, and you can see a total of 231 patients. 109 of them, 190 of them did not get a palliative care consult. And of those, 40% died. 36% died in the hospital. And I'm not saying that everybody that dies in the hospital needs a palliative care consult. That's not the point of this slide. But once palliative care is consulted, we're looking at, 85% are either dying in the hospital or discharged to hospice. So obviously we're good. I mean, you all are good, and your attendings are good at going, whoa, this person is sicker, let's call palliative care. But the other point of this slide is not everybody where palliative care is consulted died. Granted, it wasn't very many. 35 of them died or were discharged to hospice, but 6 of them lived. So again, the question is when? When are you going to discuss prognosis and the patient's values and care goals? With an art-line consult? When you're thinking about CRT? Once you're reaching, oh, baby, the tracheostomy decision way over here? Trach peg discussion? How much rapport do you need to establish with your patient and your patient's family before you discuss code status? Is code status the first thing to ask about? When we wait till the last minute or until the patient is delirious, intubated, sedated, comatose, we deprive patients and families of some very powerful and profoundly meaningful interactions.
There are so many things that people have identified are often important. A chance to complete affairs, to complete one's business affairs, to turn over important projects, to give away things not before you die and within a will, but to give things away to people that you love or just value as a colleague. To make sure that projects are passed off to, if you've been the chair of the annual fundraising event of the Rotary or your church or the chair of a committee at the bank, whatever, to pass that on so that you know that responsibility is well discharged. To say goodbye to people in not your intimates initially, but your colleagues or coworkers or the fellow you see, the guy who repairs your car, just to say, hey, thanks for being there all these years, and I may not be coming back because my health is pretty lousy. I don't think I'm going to be coming back with my car anymore. But thanks. I know we've had our differences in the past. It's been good to work with you, and if I don't see you again, thanks and bye. That sort of stuff people say they value. Deeper than that, in personal relationships of people who you love or once loved, again, a chance to say the things that would be left unsaid if any you or the other person died suddenly. You know, I read, have written a lot about the 4 things that matter most. It comes from stories that people have told me or that I've had the privilege of witnessing. Well, the things, of course, aren't things at all. They're just 4 sentences, 11 words. Please forgive me. I forgive you. Thank you. I love you. Please forgive me and I forgive you are often worth saying because, there's not been a perfect relationship in the history of our planet. Even the most close and loving relationships tend to be have some history of hurt feelings or misunderstandings, and sometimes real transgressions. So please forgive me, I forgive you. Thank you, and I love you are often like stating the obvious. In fact, of the people I'm thinking of, our intimates, our family, our close friends, those things really are stating the obvious. Usually, even if we're angry at a brother or a parent, we can also acknowledge on some level we love them. But for most of us, the love is more obvious. And, people say, I'll be counseling a family in an ICU and, the matriarch of the family has just had a stroke and can't speak and now has a fever, and we're having the discussion about, how long this should go on, about the trach and peg discussion. And after we get done talking about the medical issues and what to try and how long for this to go on and, getting through the substance of what she would want, what was in her advance directives, or if she doesn't have them, if she had them, what do you think she would have written? All of that. I'll often wonder aloud if it wouldn't be of value for them to say these 4 things to one another, that it's been, in my experience, helpful for others in the past. Not uncommonly, one of the children, usually it's an adult son, will say, "Oh, Mom knows how much we love her. She knows how much we appreciate all she's done, Doctor. You don't have to worry about that." Whether they're dying or not, if their life is at serious risk, maybe it would have value for you to say it. It doesn't hurt. And if I get response like, "Oh, she knows, Doctor, don't worry," my response to that is, well, good. Then it'll be really easy for you to get in there and say it. Because it's better said and even repeated than left unsaid.
Yeah, I think the point is that dying is hard work. It really is. And we can support our patients and their family members by giving them space and grace, which requires both truth and empathy. So we're all familiar with this, right? Code status, uh, code, you're dead. SOTO status, or scope of treatment order status, you're not dead, but you're struggling or you're dying. And SOTO status, unfortunately, full limited comfort, is actually a big spectrum that's artificially chopped into 3 segments. What I have to say about this is not a whole lot because you guys are all very familiar with this, but I have a few things to say, a few observations. One is, I think we use this one way too much. DNR full gets way too much. We have a tendency to think because a patient is in the SICU or the TICU and they're on a ventilator, they have to be DNR full. That's actually not the case. A lot of those patients are more appropriately DNR limited. If the patient's DNR full, and let's say you have a discussion with a patient preoperatively and you wind up with DNR full, that discussion always needs what I call an asterisk. There needs to be an asterisk on this full. There needs to be an exit strategy or a contingency discussion. How long does staying on life support make sense to you? What does a meaningful life look like to you? What are your thoughts about a trach? How much suffering are you willing to bear for the possibility of achieving your goals? And then DNR limited needs clarification as well. What about escalation? Are we going to escalate new life support? Are we going to start the person on inotropes? Are we going to start CRRT? It turns out that, you know, DNR limited, like I said, it's okay to be DNR limited in the ICU on a ventilator. It's also okay to get a DC cardioversion, even though you're DNR, right? If you go into a shockable rhythm, you can have a DC cardioversion as DNR limited. So then I guess the final thing to talk about here is DNR and the operating room. Usually, but not always, we suspend the DNR in the operating room. And when I talk to patients and families, that's exactly what I say. I usually use my hands and I just raise them up and I say, we suspend it. And then when the patient returns to the recovery room or the PACU, we reinstitute it. But really, every time a patient goes to the OR, code status needs to be readdressed. It's not necessarily appropriate for every patient to suspend their DNR. Some patients are so high risk, maybe they've already coded a bunch of times and you're doing a Hail Mary operation, or maybe you're doing a palliative surgery, and it would be more appropriate if the patient dies in the OR to let them die. So there's also another kind of a big, huge concept that we don't really have time to talk about today, but that is, it is appropriate to assign a patient DNR limited if that is what is concordant with their values and their goals preoperatively, and treat the surgery like a big, huge time-limited trial. And just say, like, use Nabozny's criteria and say, you know, we're gonna take our best shot. We're gonna do everything we can. We're committed to, you know, getting you better. But we know that if you're still on the ventilator 4 days after surgery, that things aren't going to look good for you. And so have those discussions preoperatively and develop, you know, your exit strategies, if you will. So I read this article, and this, by the way, also comes out of the University of Wisconsin. Gretchen Schwartz, she's a professor of vascular surgery there. The rest of these folks, Toby Campbell is a medicine doctor there. These folks are big, heavy hitters in the palliative care world, Bob Arnold and Douglas White. And I read this article about 2 years ago and realized, oh, baby, I have been doing this wrong for almost my whole career. I have been using the word want. So I have questions for you, and we'll just take them one at a time. And I just want you to unmute your mics and how often do you use the word want when talking to patients or families?
I think we use it a lot. Yeah, I think so too.
Often, very often.
Yeah. Okay. And does want honor patient autonomy?
I think our use of it is intended to honor their autonomy. You ask them what they would want in this situation.
Yeah, I think you're right. I think it's great intentions. It turns out, though, that when you ask a patient or a family want, inadvertently, you are asking the patient to make a decision right now. And you're placing the locus of power on them. And you may not be, that's not your intention, right? But as it turns out, autonomy is not based on that binary yes or no choice. It requires that patients reflect on their values that undergird their decisions. And so when you use the word want, you've short-circuited that. there's no longer any reflection. Now it's, I want the surgery or I don't want the surgery. I want CPR, I don't want CPR. So it turns out that using the word want is not patient-centered, and it does not, it short circuits a good or a robust shared decision-making process. So I would encourage you to try and stop using that word. Like I said, I read this article about 2 years ago, and it took me, and I do this for a living, as you know. I no longer operate. So, I mean, all I'm doing is having care goals discussions with patients all day long, be they medical or surgical. And it took me 6 months to get rid of that word from my vocabulary. It was so ingrained in me. And so I guess the question is, if you quit using the word want, what can you use instead? And what I typically do with patients, families, is I use substituted judgment. And I say something like, if your loved one were sitting right here and listening to and understanding everything we're talking about, what would she or he think? What would she or he feel? But most importantly, what would they say? And that gets to their values. That gets to the patient's values. It also mitigates surrogate guilt for making the decision for their loved one. And unfortunately, guilt is rampant with our family members. So this first study, risk of post-traumatic stress symptoms, this was done in France. It was a French study. It's old, 2003. But what they found was that a third of the family members that they surveyed had PTSD symptoms. A third of the folks, of the family members that had loved ones in an ICU had PTSD symptoms. 82% if they shared in end of life decisions. That's almost everybody. So when we place that power locus, if you will, onto the patient's family, and we don't clearly explain surrogate decision making, we're doing the family members a great disservice. This next study, or actually, well, this one speaks for itself, right? Obviously, nobody wants to say, let's just let him die, or let's just let her die. And then the last study here, the anxiety depression study in ICU patients, found that anxiety symptoms were present in 73% of family members, depression in 35%. So we keep talking about values, patient values. What are they? Well, of course, this is just a list of typical patient values. Any given patient may not have these values, but they're very commonly held. Good pain and symptom management, achieving a sense of purpose, functional independence, meaningful interactions with family, spirituality. This study over here by Balboni and Balboni was done in the Harvard system, and they found that, and I don't think it was Mass General, I think it was Brigham and Women's and the Dana-Farber Institute. They found that 93% of patients who were admitted to one of those hospitals with serious illness considered spirituality very important. And that's Boston, right? I mean, that's not Winston-Salem, North Carolina, 93%. If you don't ask about a patient's spirituality, they're not going to tell you. Spirituality is something that's held, it's, as one person told me once, and I really love this. She says, well, sacred things are sacred. So you hold them close to the chest. But if you're the patient's surgeon, to understand their spirituality is to understand their values. And I suggest that all healthcare providers need to be able to do a good spiritual screening. And a good spiritual screening is actually quite easy. It's only 2 questions, a positive question and a negative question. The first question is, tell me about your spirituality. Because we're all spiritual. All humans are spiritual. And the second question is, do you have any what I call spiritual pain or significant spiritual suffering? So sometimes when you ask the first question, you're going to get, what do you mean, doc? What is spirituality? What do you mean spirituality? And I typically answer with, spirituality is anything that brings meaning, purpose, and is typically related to connectedness. Meaning, purpose, and connectedness. A lot of times it's related to transcendence, with or without a relationship with what most of us call God, but some of us just call reality or the universe. And so when you get to the negative question, it's usually based on a disconnect. And I'll say something like, do you feel like you're disconnected with God? A lot of times you don't even have to do this. If you do a good job of determining a patient's values, they'll mention this right up front. They'll say, I'm a Christian and my relationship with the Lord is, and they'll fill in the blanks. You don't even have to ask the question. Anyway, other things, very commonly, patients don't want to burden their loved ones. They want to get away from going to skilled nursing facilities, and they want to avoid prolongation of the dying process. So this study is just the implications of this study are just amazing to me. So 180 patients that were 60 years old or older were asked to imagine that they had no more than 5 years left to live. And then they were given various scenarios of how that time might play out. And of those 180, 156 said that they would trade a full year of their life to avoid dying in an intensive care unit on life support after 3 weeks. That's just amazing to me. Now, of course, 11% said, no, that's the way I want to go. And so again, you have to tease this out for each individual patient. You can't assume that everybody's here or everybody's there. But the vast majority of people that are 60 years old and older say, I'll trade a whole year of my life to avoid a 3-week stay in the ICU and die on life support. So this is another study that was, and this is medical and surgical, right? It's not just surgical ICUs. This is all ICUs, but very interesting. This group of Leslie Schuneman and colleagues, she looked at 200 and
sorry, Dr. Martin. How do you think about that or interpret that in the context of once someone is actually in the ICU, they can't know
right. So that
what
yes,
at that time, right? Like I might say right now, I don't want to die in
right.
the SICU. I'll take a year off before I do that. And then I get to the SICU and I'm like, oh shoot, peg me, like
Right. Yes, very good. Very, very good question, because I think we all kind of accept greater suffering and hardship, or not all of us, but a lot of us will accept greater hardship or suffering than what we imagine. Like, I'm a bicyclist. So if you told me, let's just say I get hit by a car again, and next time I'm a quadriplegic, I'll tell you right now, I don't want to be a quadriplegic. I'd rather you not do CPR on me. Just let me die. Don't intubate me. I can't protect my airway, all that kind of stuff. The reality is, if you went against my wishes, maybe a couple of weeks down the road, I would thank you and say, oh, yeah, I didn't think I could bear being a quadriplegic, but now I can. So I think the point is, your point is very well taken. Just because we can't imagine dying that way doesn't mean that that's not the road that we would ultimately accept. But the best information we have to go on is preoperatively, before the patient is intubated. And so that's the time to discuss those tough things, right? Because once they're intubated, once they're sedated or in a coma or whatever, or delirious, you're having to discuss it with the family. Does that help?
Yeah, I think it makes sense. It just seems so confusing to me sometimes.
Yes, it is. And we don't do well with confusing and uncertainty. So anyway, back to Leslie Schuneman's article. They looked at 249 surrogate decision-making conferences across 6 U.S. academic and community med centers. And treatment options down here at the bottom were discussed 98% of the time. But patient values were only used in deliberation for decision-making 44% of the time. A robust discussion of physical or cognitive impairment, 13%. Spirituality, less than 5%. Substituted judgment conversation was started in 40 of the conferences, but only completed in 14 because it got derailed. And clinicians didn't start all those substituted judgment discussions. Sometimes it was the family members who started it. So anyway, a value-centered treatment recommendation was only offered 8% of the time. So what's happening here? What's happening here is we're offering treatments and we're asking, what would they want? Do they want a trach or they don't want a trach? Which kind of gets back to the previous slide. So this is basic spiritual care. Just ask a positive and a negative question and listen. Open-hearted, non-biased, non-judgmental curiosity. Everybody can do this. You don't have to have a master's of divinity to do this, right?
These are hard conversations. I've blown them many times myself. I've not known what to do. And with this study coming out from the Mass General where the patients had seen a palliative care physician, I realized that the gain they'd gotten was that really they'd seen 6 people who knew how to, that's the staff at the Mass General for palliative care, that they'd seen one of these 6 people who knew how to talk to them about the end of life. And so what I did was I went to those doctors and just said, I'm really bad at this. If you had to make a little list for me of what it is that I should talk about with people facing these problems, what would you put on that list? One of the doctors that I spoke to was a palliative care physician at the Dana-Farber Cancer Institute named Susan Block. And Susan encapsulated it, I thought, the best for me, at least in a way that I could use. She said that there were 4 things that she has as a little mental list in her head that she wants to talk about with a patient who's terminally ill. Number 1, do they know their prognosis? Number 2, what are their fears about what is to come? Number 3, what are their goals? What would they like to do as time runs short? And 4th, what are the trade-offs they're willing to make? How much suffering are they willing to go through for the sake of the possibility of added time? That list was really interesting to me. It was not a list asking, do you want a ventilator or do you not want a ventilator as you come to the end? Do you want your heart shocked? Do you not want your heart shocked? Her point was, if you tell me the answers to those questions, I can make a recommendation to you that says, you would not want this toward the end if these are your goals. Our misconception is that the conversation is about hard choices. Really, it's a conversation about asking people about what they want to look forward to as time runs short and what they fear the most. And the second misconception is that that arriving at what we want at the end is a kind of epiphany. Sign here, do you want hospice, do you not want hospice? It's not an epiphany, it's a process. It's a series of conversations and ups and downs as we go through a very hard series of sequence of things that happen to you as you become ill and have things come to an end.
So I love this quote. British neurosurgeon Henry Marsh, in his book, Do No Harm. And, you know, that's the bottom line is you have a choice. Are you going to have the long, messy conversation? Or are you just going to ask, do you want the trach peg or not? Study in Lancet, 10 years old now, found that 31% of patients undergo an inpatient surgical procedure in the year before their death. Okay, that's great. Maybe they're all 31% are palliative surgeries. I hope so. 18% in the last month of life. 8% in the last week of life. So just a quick slide again on the surrogate decisional guilt and ambivalence. You need to stress with your surrogate decision makers that you're not asking them to decide for their loved one. You're asking them to be their voice. And I typically use the empty chair motif, and I put my hand out and I say, imagine if your mom were sitting right here listening to our conversation, what would she say? And you have to do this over and over and over again. You have to continually reiterate the surrogate, the surrogacy role, because they're so used to making the decisions for their loved one. And then the other thing, just kind of like Maggie, she says, I'm confused. It's very common for surrogate decision makers to be confused and to be ambivalent. Name their ambivalence, normalize their ambivalence, and explore their ambivalence. Just say something like, you seem torn. I can't imagine being in your shoes. It's completely normal to be struggling with something like this. I can see that you're riding the fence, that you see the decision, but you can't make it. Tell me, please help me to understand what's bothering you most about this. So again, the when question, and as you've probably figured out by now, my favorite Chinese symbol, right? Wei Ji. Wei means danger. Ji means fulcrum or pivot point. There are 3 perilous pivot points in not all of our patients, actually just a few of our patients, surgical illnesses trajectories where we need to employ this. So we're only going to look at the blue over here. We don't have time to discuss anything in the yellow box, really. But these are the 3 perilous pivot points. Preoperatively in high-risk surgery, life-threatening disease, frailty, and older folks. Postoperatively, following complications, poor outcomes, whether they were anticipated or not, and prior to instituting any rescue plans, like the trach or the peg. Progression of disease. And this, of course, is most commonly in cancer. So this time, these are outpatient. A lot of them are outpatient discussions, right? Patient comes back, uh-oh, you did their Whipple, now they've got liver mets. You know, whatever the bad news is that comes up, but it warrants a re-goaling conversation when their disease progresses. These three perilous pivot points are when it's critical that we touch all that hurts in our patient's dis-ease, all that hurts, including their psychology, their sociology, or their connectedness or relationships, and their spirituality. You got to go there, and you've got to assess their prognostic awareness, ask permission, and then provide an honest prognosis that includes both time range and functional limitations. And notice over here, when you get to the plan, particularly this one, maybe it's still curative intent surgery. I hope it is, right? I hope it is for the patient. But even then, if this person is high risk, life-threatening disease, frail, geriatric, you need to establish a contingency plan pre-operatively or an exit strategy. So here's the actual shared decision-making steps, the steps in shared decision-making. I don't discuss code status until after step 3. Step 2 can be very, very messy. That's when, as Henry Marsh would say, that's when we commit to the long and painful exchange rather than talking ambiguities, euphemisms, and obscure technical language and leave quickly, untouched and uncontaminated by the patient's suffering. So I suggest that when you're in step 2, and again, we don't have time to discuss this, but when you're in here, you're doing this in your head. You know their diagnosis, you know their prognosis, you know the treatment options. You're doing this risk calculation, right? We're good. I mean, surgeons are phenomenal at this. My suggestion is you keep all this to yourself. Keep all this inside your brain. Do it, but don't voice it. Don't give them a bunch of numbers and percentages and ask them to choose. Rather than that, you enmesh this with their values, their expectations, their fears, and their levels of suffering that are unacceptable to them. Maybe it's go to a sniff, maybe it's go to an LTAC, maybe it's a trach, maybe it's a peg, who knows? If you don't ask and you don't get these values from them, then, and this is the messy process. And then finally, after I've developed a value concordant care plan that is truly patient-centered, after that, I'll typically say something like, there's one more tough subject that we need to discuss. If your heart were to stop and you were to die, right now, we would be obligated to do CPR. That really just doesn't make any sense, given your values and how much suffering you'd be willing to undergo. Or perhaps it does. Again, we can't impose our values on the patient because then it's no longer patient-centered. But for most folks, doing CPR is nonsensical when it comes to their values. So we're going to switch subjects just a little bit, and I guess we're 2 minutes over. I only have 2 more slides. So pain and symptom management with withdrawal of life support. So for both pain and dyspnea, we want to use low dose opioids, IV, right? And you're going to base it on their IV requirements. So if they're already on, Dilaudid drip or fentanyl drip, you're going to base it on that. if they're not, and they're opioid naive or fairly opioid naive, and they're not getting a lot of opioids, maybe they've got a head injury or something and you're not sedating them for neuro checks, you just use PRN bolus doses. Number 2 is benzos. Once you add benzos, you are significantly increasing their risk of decreasing their ability to breathe or their respiratory drive. So at that point, it's kind of a catch-22, right? Could I be hastening this patient's death? Is the question that is probably arising in your mind. And what we use in palliative care is what we call the principle of double effect. So the effect that we're trying to get, that we know we can get, is relief of suffering. Dyspnea is a horrible thing to experience. And so we know that we can relieve their dyspnea with opioids, or maybe we need to add benzos. There is this other effect, which is decreasing respiratory drive, that occurs some of the time, but not all of the time. And we don't even know how much, right? And so that's the bad effect. But with the principle of double effect, because we're trying to do what's best for most of us, and I'm not suggesting all of us, but for most of us, we go ahead with the plan, and that's the opioids and the benzos. Sometimes I'm explicit about this principle of double effect to families. Sometimes I'm not. It just really depends on, you just have to read the family and kind of decide. Then the other thing to say is sometimes we're going to start a continuous drip before we withdraw, do the compassionate extubation. Other times we're not. So sometimes family members are grasping onto this concept that they still want to hear from their loved one. They still want their loved one to make the decision. You and I know, well, their loved one's not likely to, to come out and say, yeah, you did the right thing. They've got a GCS of 11T, right? You don't know when they're extubated whether their GCS is going to be 11 or 15 because they're intubated. So a lot of times with families like that, I will give them the opportunity, and I won't start the IV drip. We'll just have, the nurse will have the PRN boluses available. We do the extubation and then quickly give them this if in fact they're suffering. Anxiety, Ativan. Oropharyngeal secretions, it turns out glycopyrrolate actually doesn't help much. Not proven anyway. Helps us. Positioning, suctioning works better. The bottom line here is you need to tell your patient's family, your loved one may experience the death rattle. And although it's really harrowing thing for you to hear, your loved one is not experiencing distress. And then, of course, we turn the monitors off and offer spiritual support. Other end-of-life considerations. So this not necessarily in the intensive care unit. Artificial nutrition, from an ethical standpoint and a legal standpoint in this country, is not considered food. It's considered life support. It's a life-sustaining medical treatment, and it offers no benefits in terminal illness. It doesn't extend their life, doesn't prevent aspiration, doesn't prevent bed sores. It's not enjoyable. And for instance, the American Geriatric Society advises against PEGs in advanced dementia. A lot of times to have these discussions, I have to get into when food is not love with the family, because we feed the people we love, right? And we do it from the time, our babies are born. The other thing to know here is that dying patients' kidneys are shutting down. They're typically less thirsty. They're less hungry than ever. IV fluids or artificial hydration is just going to increase their pulmonary edema. nausea. You want to block dopamine and serotonin. If they have continuous nausea, you want to give them scheduled Haldol. That kills the dopamine receptors, and then a PO on Dancitron or any of the citrons. We use Zofran here, which kills the serotonins. Cannabinoids work. Ginger works, proven. Terminal delirium and agitation. So most of these folks are going to be, up on the floor. They've had their trauma, but unfortunately now they have, post-op delirium or post-traumatic delirium or post-ICU delirium, and they have agitated delirium. What we're bad at recognizing is the hypoactive delirium, right? So delirium, it can come from opioid toxicity, but more commonly, it comes from uncontrolled pain. So although I have number one here is Ativan, number one actually should be a test dose of an opioid. See if that helps. And then question constipation, urinary retention, day-night cycle interruptions, bring familiar people, smells, textures, blankets, whatever you can bring. Talk about hospice. But if you're in the meantime, before the patient goes to hospice or whatever, Ativan is the number one. If Ativan doesn't work, then Haldol, the so-called ham sandwich, Haldol, Ativan, morphine, although we don't use morphine because of the renal failure thing. So anyway, those are some suggestions. What about your patients with terminal malignant bowel obstructions or intracutaneous fistulae that now, we've had the hard discussion. We're going to stop the nutrition. We're going to stop the other life support. Fentanyl for pain, high dose dexamethasone, an H2 blocker, because the H2 blockers decrease this stomach output better than the PPIs, octreotide, which will shut their gut down, plus or minus glycopyrrolate, and of course, treat their nausea. So final thoughts: allow space for and attend to emotion. Gracefully explain that no one is giving up on the patient. Allowing the patient to die naturally and comfortably emphasizes their value, honors them for who they are, returns to what matters most, and reveres their values and spirit. And always reiterate continued support.
This completes the Surgical Palliative Care Society webinar on end-of-life care for patients. We sincerely hope it was helpful to your primary surgical palliative care practice. Please visit spcsociety.org for more content on surgical palliative care topics. Thank you and have a great day.